The patient's name was Elena, 58, in hospital cardiac arrest on the cardiology ward, asystole for 19 minutes. When we restored circulation, she was intubated, sedated, pupil sluggish. 3 days later, extubated, she described the code in order. The drug I pushed, the junior resident who swore, the color of my watch strap. She had been, by every instrument we had, dead for those 19 minutes. I could not account for what she knew. I have been a physician for 22 years. This is one of the cases I cannot explain. Elena is not unique. She belongs to a pattern documented for at least a century and studied rigorously for the last 3 decades. In 2001, the cardiologist Pim van Lommel published a prospective study in the Lancet following 344 survivors of cardiac arrest across 10 Dutch hospitals. 18% reported some form of structured recollection from the period of unconsciousness. 12% described what he classified as a core near-death experience. A sense of detachment, lucid cognition, occasionally verified perception of the room. The finding that unsettled the cardiology community was not the content of the reports. It was the timing. These were patients in ventricular fibrillation, with no measurable cardiac output, reporting ordered, sequential, remembered experience. Bruce Grayson, a psychiatrist at the University of Virginia, had already, in 1983, published the Grayson NDE scale in the Journal of Nervous and Mental Disease, a 16-item instrument that let these accounts be compared across cultures and decades. When applied retrospectively to historical case reports, the pattern held. The Swiss geologist Albert Heim, falling from an alpine ridge in 1892, described the same architecture. Time dilation, panoramic life review, absence of fear. He later collected 30 similar accounts from survivors of industrial accidents and mountaineering falls and published them in the Yearbook of the Swiss Alpine Club in 1892. The phenomenology Heim described in Bernese Climbers in the 19th century matched, almost line for line, what van Lommel's cardiac patients described in Arnhem in the 1990s. The most recent and methodologically ambitious entry is Aware Cited, led by Dr. Sam Parnia at NYU Grossman School of Medicine and published in Resuscitation in 2023. 567 patients with in-hospital cardiac arrest across 25 hospitals in the United States and the United Kingdom, enrolled between 2017 and 2020. 53 survived to discharge. Of the 28 interviewed, 11, just under 40%, reported memories or perceptions consistent with awareness during the arrest. The pattern, then, is this. A minority of patients who survive clinical death return with structured, often transformative recollections of the period during which their brains were, by every available metric, not supposed to be producing anything. The numbers are small. The signal, across a century, and multiple independent research groups, has not gone away. The mainstream position is coherent, defensible, and held by serious people. It deserves to be stated carefully. The argument runs as follows. When cerebral perfusion drops below roughly 20% of baseline, organized cortical activity collapses within seconds. The isoelectric EEG that follows is not a state in which experience can be encoded. Therefore, any memory a patient reports from that interval must have been formed either just before the collapse or during the reperfusion phase, as the cortex came back online. The brain, under these conditions, is a malfunctioning organ. It confabulates. Michael Schur-Mayer, writing in Scientific American, has argued consistently that near-death reports are best explained as hallucinations generated by a hypoxic, hypercarbic brain awash in endogenous opioids and, often, exogenous anesthetics. Anil Seth, the neuroscientist at Sussex, frames consciousness itself as a controlled hallucination, a predictive model the brain constructs, and views NDE phenomenology as that model degrading under stress, not as evidence of consciousness independent of the substrate. Sam Harris, though more measured, has noted that extraordinary claims about mind without brain require extraordinary evidence, and that the existing evidence does not clear that bar. There is also a concrete neurobiological mechanism to point to. In 2013, Jimo Bore-Gijin and colleagues at the University of Michigan, publishing in the Proceedings of the National Academy of Sciences, reported that rats undergoing induced cardiac arrest showed a surge of highly coherent gamma band activity in the 30 seconds after circulation stopped, gamma power exceeding waking baseline, with strong cortico-cortical coupling between the posterior cingulate, precuneus, and temporoparietal junction. These are the regions implicated in self-referential processing, autobiographical memory, and the sense of body ownership. In 2023, the same group published a human case series in PNAS describing similar gamma surges in 2 patients at the moment of terminal extubation. The proposed mechanism is disinhibition. As inhibitory GABAergic tone collapses, glutamatergic pyramidal neurons fire in a brief, hypersynchronous cascade. A last electrical flare. On this model, the near-death experience is not a window onto something beyond the brain. It is the brain's final, vivid, self-generated hallucination, assembled from the exact anatomical substrate we would predict. The reports feel more real than waking life, because the circuitry for the feeling of reality is firing harder than it ever has. This is a strong explanation. It accounts for the phenomenology. It is grounded in measured electrophysiology. For most cases, most of the time, I think it is probably correct. The consensus holds for most cases. It does not hold for all of them. And in medicine, the residual, the cases that refuse to fit, is where the work is. Consider a case reported by Michael Sabom, a cardiologist, in his 1998 book, Light and Death, drawn from a 1991 operation at the Barrow Neurological Institute in Phoenix. A 35-year-old woman, Pam Reynolds, underwent resection of a basilar artery aneurysm under hypothermic cardiac arrest. Her core temperature was lowered to 60 degrees Fahrenheit. Her heart was stopped. The blood was drained from her head. Her EEG was flat. Her brainstem auditory evoked potentials were absent. The clicks delivered through molded earpieces produced no response at all. In every operational sense, her brain was off. On recovery, she described the bone saw used on her skull, its sound, its shape, and a conversation between the surgical team about the caliber of her femoral artery. The details were, per the surgeons present, accurate. Consider the aware too, finding that unsettles me most. In a subset of patients, Parnia S team recorded normal or near normal EEG activity, gamma, delta, theta, alpha, up to an hour into CPR. Not a terminal flare of 30 seconds. An hour? In patients receiving chest compressions, with cerebral oxygenation measured by regional saturation monitors well below the threshold for sustained cortical function. The signal should not have been there. It was there. Consider Elena, the patient I opened with. Her account included the phrase my junior resident used when the first epinephrine dose failed. A phrase spoken, per the code recording, at minute 11. Minute 11 was 4 minutes after her end-tidal CO2 had dropped into single digits, 7 minutes after her last organized rhythm. The Bore-Gijin model gives us 30 seconds of gamma. It does not give us minute 11. The question is not whether a dying brain can generate vivid experience. It almost certainly can. The question is whether a brain with no measurable perfusion, no organized electrical activity, and no evoked potential response can acquire and later recall specific, time-stamped, externally verifiable, auditory information? Those are different questions. The second one is the one the standard model does not yet answer. For any such recollection to be veridical, several faculties must have been concurrently intact. Auditory encoding at the cochlear and brainstem level, discrimination of speech from noise, binding of the phrase to a temporal index, consolidation into long-term memory, and later retrieval through a reperfused that was itself ischemic at the time of encoding. Each of these is, individually, hard to explain under arrest conditions. The conjunction is harder. I want to be careful here. One auditory match in Aware II out of 28 interviews is not proof. The visual targets, the tablets displaying images above the patients, were not identified by anyone. Pam Reynolds is a single case, forensically detailed but uncontrolled. Elena is my patient, not a study. None of this is evidence that consciousness survives the brain. It is evidence that our model of when and how the brain stops producing experience is incomplete. Those are, again, different claims. The confusion of the two is what poisons the literature in both directions. What would it take to settle this? Parnia S group has now launched Aware III, a successor protocol that attempts to address the methodological gaps in Aware II. The earlier study placed tablets on high shelves in rooms, displaying randomized images on the theory that a patient reporting an out-of-body perspective from the ceiling should be able to identify them. No patient did. The failure is instructive. It may mean the out-of-body perception is not perceptual in the ordinary sense. It may mean the targets were in the wrong place, or that the survivors who reach interview are not the ones who had the experience, or that the phenomenon is too rare to catch in a sample of 28. Aware to read you. Broadens the stimulus set and adds continuous high-density EEG and regional cerebral oximetry throughout the arrest, rather than sample points. But the deeper problem is instrumental. We do not have a consciousness meter. We have proxies. Scalp EEG, which averages the summed activity of billions of neurons and misses most of what happens in deep structures. Functional MRI, which requires a still, living patient in a magnet, useless in a code. PT, too slow. Intracranial recording, ethically impossible in this population. Every instrument we have measures the shadow consciousness casts on physiology. None of them measures the thing itself. This is the gap the channel is named for. In clinical practice, we monitor 4 vital signs: heart rate, respiratory rate, blood pressure, temperature. Pain is sometimes called the 5th. I would argue, carefully, that consciousness is a candidate for that designation. A physiological state with clinical consequences, one we infer constantly and measure never. We document Glasgow Coma Scale scores. We observe pupillary response. We ask, if we can, whether the patient is oriented. We do not have a waveform for awareness. We have no instrument that tells us, in real time, whether the person on the table is experiencing there. Until we do, the aware data will remain ambiguous because the ambiguity is built into the measurement floor. There is a clinical consequence to this ignorance. The Aware II study identified 2 cases of CPR-induced consciousness among 28 survivors. Patients who emerged into awareness during chest compressions, aware of the pressure, the voices, the helplessness, unable to signal. Current protocols do not include sedation. They cannot, without compromising the hemodynamics of CPR itself, if a fraction of patients are experiencing their own. We are, without malice, causing a form of suffering we have no protocol to address. I do not know how common this is. Neither does anyone else. That we do not know is the part that should disquiet us. Elena went home on day 11. Her ejection fraction recovered to 40%. She returned to work 6 months later, part-time, at the accounting firm where she'd been a partner for 19 years. She told me, at her first clinic follow-up, that she was no longer afraid of dying. She also told me that she had stopped arguing with her sister, whom she had not spoken to in 4 years before the arrest. She said the life review had shown her what the argument had cost them. I did not know what to do with that information, clinically. I wrote it in the note. The phrase she recalled from the code, the one my resident used at minute 11. I have not told you. I will not. It is the kind of detail that, if repeated, becomes a story. And stories are what this field does not need more of. What it needs is better instruments, larger cohorts, continuous recording through the arrest interval, and a willingness on the part of serious clinicians to hold the question open without either collapsing it into the supernatural or dismissing it into artifact. I do not know what happened to Elena during those 19 minutes. I know what my instruments told me, which was nothing. I know what she told me, which was specific, checkable, and in the checkable parts correct. I know that the distance between those two knowings is the exact size of the problem. I am not certain she was conscious. I am not certain she wasn't. I am certain we cannot yet tell the difference.